Thank you so much for this invitation. I'm really excited to be here and to tell you a little bit about the history of what we've been learning in the brains. And I had a great setup this morning with Dr. LaFurla talking about the positives of the mouse models, but needing the human because you can't exactly model our brains. And then the last talk by David, we're showing that we're getting much better pictures of what's happening in the brain, which is really exciting. So what I'm going to do is I'm going to talk to you about four things. One is something that's already been mentioned, that Alzheimer's disease is often mixed with other pathologies. I'm going to talk to you about risk factors. How do they work? Why are certain things a risk for Alzheimer's disease? And then it's been alluded to already that older people without cognitive impairment have a lot of Alzheimer's pathology. What does that mean? And that we still don't understand a lot of it. We know there's a lot of things happening in the aging brain, but we still do not understand everything. So this was already described to you that Augusta was described by Eloise Alzheimer, a 51-year-old woman, in a beginning history of Alzheimer's disease, that it was thought to be a pre-senile condition, not a senile condition until the 1960s. But why I bring this up is because we still use the same markers that Alzheimer used when he described Alzheimer's disease: neuritic plaques and neurofibrillary tangles. We still do silver stains. So this is a silver stain of the brain. It looks like a busy stain. It stains, you can see a lot of the neurons and connections. This is what it looks like when you have Alzheimer's in the human brain. And these are the plaques and tangles of Alzheimer's. I don't think it's too hard to understand why these neurons wouldn't be able to communicate with each other when they have this mass of tangles and plaques between them. And this is just a little bit higher power of the plaques and tangles. So even though that doesn't sound very encouraging that we're still using the same diagnostic measures, we do know a lot more about what's happening in the brain. And indeed, we know that the protein, he didn't know what protein this was, we know that the protein accumulating in the brain is beta amyloid. And there's been a lot of research into why is this accumulating, and a lot of evidence that suggests that it's primarily causing something early on in the disease. So very important, and I don't want to underestimate the importance of Alzheimer's disease pathology as you hear about some of these other pathologies, because certainly Alzheimer's disease pathology is the elephant in the room. It's significant, it's important. It's just not the only thing. So when we look at a brain pathologically, the Alzheimer's brain looks atrophic. And what's that mean? It's shrinking, it's getting smaller, it weighs less. You can see here on the left the Alzheimer's brain, which is shrunken. And you can see even on cross-section, much easier that it's, that the ventricles are enlarging. There's so much loss of tissue that those holes in the center of the brain are getting bigger. You can see the normal brain on the right-hand side. And there are certain features of an Alzheimer's brain. Their hippocampus does shrink, there's no question, and that's where memory is partially stored. The problem with this is that we see shrinkage of the hippocampus in other diseases. It's not just Alzheimer's disease. So we can see it in Pick's disease, other frontal temporal lobe degenerations. We can see it with vascular dementia. We can see it even with, quote, normal aging, meaning you can have a shrunken brain and still have good cognitive function. So you can't make a diagnosis of Alzheimer's disease using this MRI technique, right now anyway. Maybe with some of the quantitative measures that'll change, and with machine learning. But as of right now, we can't make a diagnosis. So the information I'm going to provide today is all about humans, and it's really because of the altruism of these older people who enrolled in our studies over 20 years ago. First, the religious order study, where we enrolled nuns, priests, and brothers from throughout the country. And we wanted to see what's the natural progression of cognitive aging. And in order to do that, we need humans. We need to do cognition yearly on them. And what we really need was their brain after death, to see really what is going on in the brains of both normal, demented, MCI, everywhere in between of older people. We didn't have that. All we had were the people with dementia and then sometimes people who were controls. We didn't really know this natural history. So we enrolled people across the country, and a condition of enrollment was that they donated their brains. We followed that study up with something called the Memory and Aging Project, which is within Chicago. And here we wanted to get a little bit better representation of the population. So we have a more diverse socioeconomic class, more racial diversity, ethnic diversity, and we thought that might be more reflective of the general population because people rightly said, well, the religious orders, they get good health care. They're not going to be the same as other people. They take better care of themselves. So how about other aging populations? So we did that. Between these two studies now, we have over 3,000 enrolled in these studies being followed longitudinally within Chicago and across the country. And we have over 1,500 autopsies on them over the past 20 years. And then I'm just going to show you some of the pictures of where they come from. I should also mention two things that are really important here, is that we have very high follow-up rates. So people who drop out of studies tend to be different than people who don't. And so we want to know what's really happening. We have to keep following them. And the religious order are incredible about staying in the study. We have like 95% follow-up rates. The Memory and Aging Project, a little bit more difficult, but still very good. And we get very high autopsy rates. When they commit, they really do give their donation. And in the Memory and Aging Project, we also work very hard at getting the brain. Because remember, the brains that come for autopsy often are when the family's like, oh, I'm not sure what this was, or the doctor wasn't sure what it was. So they tend to be a little bit of an odd group sometimes. So this is what it looks like. The red dots are where we go. It's an older slide. I need to update it because we are still actively recruiting, and we are in particularly looking for racial and ethnic minorities and men. But here's just some pictures of this. Here's from across the country. We have a big team that goes out to these places. What's really helpful about the religious order study is that they stay living in one place for long periods of time. And you can see many of them have cemeteries in front of their monasteries, which is really impressive, right? So we can follow people right up to the time of death. Here's another example. I believe this was in White Plains, New York. Here's some of our participants in our studies. This is in Chicago where we go. Sometimes it takes as long to go somewhere in Chicago than it does to some of these other cities. But we go throughout the Chicagoland area. And here we're able to do a lot more with our participants because they're in the area, so we're able to do more scanning techniques, more things than we could do for people who are, let's say, in California. So here we also get spinal cord, nerve, and muscle too. Here's some of the sites that for the Memory and Aging Project. Some of these senior living sites are quite nice, but we do try to get a wide socioeconomic class, so you can see here that we also do have low-income housing. And here's some of our participants, or potential participants, listening to a lecture, and then they're going on to say, are you interested in being part of this study? So we work very hard at getting people to come in these studies and telling them how important it is to be in these studies. So what I'm going to do is then start with this mixed pathology idea. You've been hearing it's not only Alzheimer's disease, what else is it? So I'm going to show you some of the things that we found in these brains of older people who have dementia and who don't have dementia. So we see Alzheimer's disease, of course, plaques and tangles. We see vascular disease, macroinfarcts, which are strokes. But the other thing that we see is other degenerative pathologies like Lewy body disease, which is something that you see in Parkinson's disease. We also see something that's relatively new, we just learned about within the past 10 years, something called TDP-43 pathology. And then we see a host of other microvascular pathologies, things that we can only see under the microscope that show that you're not getting sufficient blood flow to your brain, and there's vascular injury as a consequence. So these are some pictures of the brains. This is a infarct here, so this would be someone who had a stroke. Sometimes we get these cases, a lot of times we get these cases, and the older person never knew they had a stroke. Lots of times they're small and subclinical. Here's something called a microscopic infarct. This is something we only see under the microscope. It has similar risk factors to having a stroke. Blood pressure elevation, diabetes, same things, same sort of risk factors. Here we have atherosclerosis at the base of the brain, same thing that happens in your heart, large vessel disease. Around a third of our older people who die around the age of 90 have moderate to severe atherosclerosis. This is small vessel disease or arteriolar sclerosis, strongly related not only to blood pressure and diabetes, but to aging. Very common to see this in the older person's brain, very strongly, by the way, related to those white matter hyperintensities that you see on imaging. Very common in diabetes, hypertension, very much related to getting strokes, both of these vascular diseases. And then we have cerebral amyloid angiopathy, which is a little bit different, related to amyloid plaques. What's interesting is when we see these vascular pathologies, most of the time it's on a background of Alzheimer's disease. So we usually see these together. We don't see just the vascular or just the Alzheimer's, and I'll show you that. The other thing we see are other neurodegenerative diseases. So here is a classic Lewy body up here, which we see in the Nigra and people with Parkinson's disease, but we've known for a long time that you can see these in patients with dementia. And they may or may not look different or be atypical from your typical Alzheimer's disease patient. And then here we have TDP43, which is another abnormal protein. And again, the vast majority of the time, it's on the background of this Alzheimer's disease pathology. So we showed over 10 years ago now that when we looked at participants from our studies when they died with and without dementia, that they had a range of pathology. So here's the people that we diagnosed at their last visit, which is on average around 6 months prior to death, with probable Alzheimer's disease, and this is the pathology that they had in their brain. Everything that's blue is Alzheimer's disease pathology, but it's only the light blue, which is Alzheimer's disease pathology alone. The darker colors and this greener color are all mixed pathologies. So over half of the people had either Lewy bodies or macroscopic infarcts, even though we called it, experts called it Alzheimer's disease. The other thing to note in this, and you can see here, this pink here is people with vascular dementia, so there was some misdiagnosis as expected. The other thing to notice here is people with mild cognitive impairment. By the time we call it mild cognitive impairment, over half of them have full Alzheimer's disease pathology in their brain. Not surprising that it's not easy to treat at that stage already. And then even more striking is what's been alluded to in the other talks, is that people who die, older people with no cognitive impairment, a third or more of them have full Alzheimer's disease pathology in their brain and don't know it. So that's pretty striking. But it's one thing to say they have it, these other pathologies. It's another to say, is it bad for you? So we looked at Alzheimer's disease pathology going up, the probability of having dementia, and this lower line is, as your Alzheimer's pathology goes up, the chance of having dementia goes up. And what the red line shows, that for every level of Alzheimer's pathology, if you have a gross infarct, we can see an infarct, your odds of having dementia go up. And this has been shown previously in the Nun study. We later went and said, how about these little tiny little infarcts that we're finding in the brain? These little things that nobody can see on imaging. They're under the microscope only. And indeed, we found that you go from around a 20% odds of having dementia with this much Alzheimer's pathology to over 50% odds of having dementia if you have both a macro and one of these little tiny microscopic infarctions. Then we said, well, how about this vascular disease? Around a third of our older participants have either or atherosclerosis, severe atherosclerosis, or severe small vessel disease, arteriolar sclerosis. Is this telling us more about their vascular health than just seeing these infarcts? And indeed, again, if you look at the probability of dementia, or of Alzheimer's dementia being diagnosed, here's just Alzheimer's pathology. And then you have around a 20% odds of having dementia. It's not very much Alzheimer's pathology in this person's brain. If you have a macroinfarct, a microinfarct, moderate or severe atherosclerosis, and moderate or severe arteriolar sclerosis, your odds have just gone up to over 60%. So you can see that these vascular pathologies are really important in the brain. And then people say, well, how common is it? It's amazingly common to have this. So if you look at this chart here, this is people with Alzheimer's disease dementia. The yellow is atherosclerosis. Yeah, I think that was right. Yellow was atherosclerosis. The red was was both athero and arteriolar sclerosis. And the cross hatches are people who have infarcts. So this is all to say that if you have Alzheimer's disease dementia in the community, you die, your brain comes to us at the age of 90, you have a 75% chance of having a macroinfarct, microinfarct, severe large vessel or small vessel disease. So extremely common, so not so surprising that those risk factors that are good for your heart are good for stroke, protecting stroke, also protect you, because these things are increasing the likelihood you're going to exhibit dementia. So the news gets worse in that there's other things going on too. It's not just vascular disease. We also see these Lewy body disease in around 25% of our people who die with Alzheimer's. And we also see TDP-43. This is just showing that Lewy bodies are actually quite toxic in the brain, that over and beyond those infarcts, it really pushes your odds up of having a dementia. More recently, we've learned of something called TDP-43, which was originally described in frontal temporal dementias. We thought it was a relatively rare protein abnormality, but as soon as we started staining brains of older people, we found out they too have this protein abnormality called TDP-43. And it's bad for you. If we find this in your brain, it's very bad. And what's interesting about TDP-43 is if you have this alone, your impairment is very similar to what we see in Alzheimer's disease. It's memory impairment. So kind of opens up the door for these amyloid negative memory impairment people. There's another reason that they can have really severe memory impairment, and TDP-43 is one of those reasons. It's also associated with hippocampal degeneration. So when we talked about the specificity of this hippocampus degenerating, it's not specific for Alzheimer's disease. People can have TDP-43 pathology. And we're really just learning about this now. We had a consensus panel. There wasn't a great consensus in the community about the name we chose, but we did choose the name LATE, which stands for limbic predominant age-related TDP-43 encephalopathy. It does indeed occur late in life, but people did have a problem, some people had a problem with us using that name. But otherwise it was kind of a mouthful, so we did come up with that name for this syndrome. And we came up with criteria also for the syndrome. What I want to point out is that like these other things that we're finding in people's brains, it's often again on a background of Alzheimer's disease pathology. So when we look at our Alzheimer's disease group, we can see that over half of them have TDP-43 in their brain. And what you can see here is if you look at a person's odds of dementia, Alzheimer type dementia, if you have TDP-43 alone, you have an increased risk. If you have AD alone, you have an increased risk. But if you have both AD and TDP, you have an increased risk, you have worse memory, you have a smaller hippocampus, and you're going to decline faster. So TDP is really telling us something about these brains of people with Alzheimer's disease, important protein. So we're not the only ones with the Religious Order Study and Memory and Aging Project that have described these mixed pathologies. It's really now been shown over the world that older people, when they die, in their 80s, in their 90s, more often have infarcts or Lewy bodies or TDP-43 in their brains. So we looked at this more recently, looking at all these pathologies that I've told you about, all the infarct pathologies, all the protein abnormalities, and we said if we look at our group now with over 1,000 brains, how many people really just have pure Alzheimer's disease? And we came up with a whopping 3% with probable Alzheimer's disease. And so you can see here that we confirm the diagnosis. So usually if we say it's Alzheimer's, it is. There's Alzheimer's in the brain, but the vast majority of time there's other things in the brain. Now, not each of those have an equal impact to the brain. So one small infarct may not be doing what amyloid and tau is doing, but it's important to know that there's other targets within these aging brains. And this is just another picture similar to what I showed you at the beginning. Now just looking again, yes, people with probable Alzheimer's have Alzheimer's pathology, but the vast majority have vascular disease, a very majority has other degenerative disease. There's some people that we're misdiagnosing. And then again, people with MCI, people with no cognitive impairment commonly have pathology in the brain. The thing to see here is that the amount of mixed pathology is dramatically going up. So we want to also look at, maybe there's like one combination all of our participants have. Maybe they all have AD, infarcts, and atherosclerosis. We should really look at that. What are these common combinations that we can target? So we were hopeful. So here it was a little bit less than 1,000 of our participants. Again, AD was rarely alone. We did have AD, TDP-43, and cerebral amyloid angiopathy as our most common comorbid diseases, but they occurred only in 20 to 40%, 22 to 41 people, excuse me. And actually we found out of 9 pathologies, over 230 combinations of pathologies. In most combinations, again, less than 50 people. So AD alone was actually the most common in this particular study at 6%. But you can see here AD and cerebral amyloid angiopathy, then with TDP, just having infarcts in your brain, having atherosclerosis in your brain. So there's a lot of inter-individual variability across all the people that we're putting into these trials. Some may have a lot of these things, some may have very little, but it's going to alter the chance that an anti-amyloid agent's going to work. You have less power then, right? Overall, 236 combinations of pathology. So it begs the question, why put all of our eggs in one basket? Why are we only studying amyloid and tangles? What if we did look at vascular disease or Lewy body disease or TDP-43? So we looked at what's the attributable risk of dementia. If we got rid of a pathology, how much dementia would we get rid of? And what we found these numbers vary a lot depending on the cohort. So it's cohort specific to the Religious Order Study, Memory and Aging Project, dying over the age of 90. So you can't extrapolate to other groups. But if we got rid of the pathologic AD, we'd get rid of just slightly over half of the dementia, Alzheimer's dementia. If we got rid of the other degeneratives, more than a third. And if we got rid of all of the vascular pathology, again, almost half. And it doesn't add up to 100 because remember, they're all interrelated with each other. So statistically, it ends up being overlapping. So again, this is cohort specific, and there's interrelationships between these pathologies. And I should mention also, it does not account for unexplained pathology. These models assume the pathology explains everything, which it doesn't. Okay, a couple more things about special populations. Our demographic is changing. People are living older and older. And so being 70 and having Alzheimer's is likely not the same as being 80 or being 90 and having Alzheimer's disease. We looked at that. Other people have looked at it. We have the 90+ study here at UCI, which is giving a lot of information on people over 90 with dementia and what their pathology is. But what we found in our group was that, yes, Alzheimer's disease, the clinical diagnosis is going up. However, it's not the single pathologies going up. It's all this mixed pathology. Not surprisingly, more vascular as you get older, more of these other things accumulating as you get older. So more of a problem in this over 90 group. We also found that if you look at Black people, they also have more mixed pathologies. Now this was done in a clinic, so it's not representative to the population. We found more Lewy bodies in the clinic for Black people, which is not surprising. If you know about Lewy body disease, people have more behavioral problems, so they end up coming to the doctor more easily. But we did find more vessel disease too. So we can't assume that whites are reflecting everything happening in the other populations. Let's talk a little bit about risk factors. What can we learn more through risk factors and pathology? So there's a lot of things that we're told affect our risk of Alzheimer's disease. There's lifestyle factors, physical activity, Dr. Kottman talked a lot about, the environmental factors, education, there's psychosocial factors, genetic factors, there's sex, there's medical factors, and all these things are working somehow through our brains and our brains respond in a way where we lose cognitive function. And we know some of those things that happen in the brain. We don't know everything happening in the brain, but we can look at that by looking at our participants in these studies. So here we looked at late life blood pressure. So we took an average of older people's blood pressure, whether or not they had hypertension, and said, what happens to the brain in people with elevated blood pressure, even at these older age groups? And what we found was that indeed, the people with elevated blood pressure had more gross infarcts as well as microscopic infarcts in their brain. Now, we also found this counterintuitive finding that as their blood pressure declined in aging, they also had more infarcts. So maybe not getting enough blood flow to the brain was also bad. But I think this is interesting given the new data suggesting that fierce blood pressure control is really important for the brain. We also found that vitamin E, which is, something that's been talked about mostly in foods as a possible therapy for, or a benefit for Alzheimer's risk. We looked at the brains of our older people and looked at how much vitamin E do they have in their brains. And what we were able to see is that there was some association, not super strong, but there was some association between the gamma tocopherol in the brain and how much amyloid you had in your brain. So we can start looking at risk factors and how risk factors are working through the brains of older individuals. And interestingly here, don't go out and just go buy alpha tocopherol. This was gamma tocopherol, which is different than alpha tocopherol, and it's very likely that the balance between the two is quite important. So I think we really need to understand more about how these things are interacting in the brain. So there's other things that we have found. We found that people with purpose in life or lack of purpose in life had more infarcts in their brain. Again, a relatively small effect, wasn't accounting for all the reason that we saw purpose in life protective from Alzheimer's disease, the clinical diagnosis. We also have looked a lot at sleep and sleep fragmentation as a risk factor for Alzheimer's disease, and we have found that people with sleep fragmentation at night have more vascular disease in their brain also. And then we've looked at some consumption, dietary consumption, like seafood, and I'll show you a little bit more about this in just a second, and that this may also be related to how much neuropathology you have in your brain. So we can start linking some of the things we're doing during life to what pathology is changing during in the brain. Okay, so before we talk more about risk factors, let's talk about all this pathology we're seeing in the brains of people without cognitive impairment. So neuropathologists have seen this for many years, where people without dementia come for autopsy and they have all this Alzheimer's pathology. We were told, oh, the neurologist didn't capture it in time, they probably did have dementia. But we have very good evidence now, with 6 months between death and seeing the brain, that lots of people have this pathology. And now we also have PET amyloid and PET tau, which told us the same thing, that you can do a scan of the brain and older people have Alzheimer's disease but aren't experiencing the symptoms. So this is what it looks like. Around a third of older people having full Alzheimer's disease pathology in their brain, again in the blue. Now I should make the caveat that they have less, so it's not as severe as the other people, but there's a lot of overlap. And why is it that some people with the exact same amount of pathology, one will have dementia and one will not? And we don't know the answer, but us and others are really trying to understand that. Are there better repair mechanisms? Is it less inflammation, more inflammation, just a better inflammatory response? How about compensation? If you do crossword puzzles and you build connections in your brain, what are the things that we can do to be one of these people who has pathology but isn't exhibiting symptoms? Because that's just as good as not exhibiting symptoms. Well, maybe not just as good, but I'll take that rather than exhibiting symptoms. So also what we're finding, which is I think fascinating, is that when I was training in neurology, I was told if you think you're having memory problems, you don't have Alzheimer's. People who have Alzheimer's disease, they don't know they have memory problems. We know now that that's not true. We know now that having symptoms or subjective complaints of memory problems does tell us something about what's happening in your brain. And there's been multiple studies now, and I have 2 up there from our group, where we looked at memory complaints and we found a direct relationship between memory complaints in older people and the amount of Alzheimer's disease pathology in their brain. So doctors should not be ignoring older person's complaints. They're noticing a decline, and you know what? They're seeing a decline. There really is a decline, and something is happening in their brain. And there's other things happening from that Alzheimer's pathology, very likely. It could be behavioral changes. It can be olfactory impairment, which us and other people have found, that your sense of smell goes down. The other things we recently reported is that in our older religious order study and memory and aging project group, their susceptibility to scams, even with normal cognitive impairment, no cognitive impairment, excuse me, normal cognition, their susceptibility to scams went up if they had this pathology in their brain. And fraud is a huge industry in the elderly population. So we find that if you're susceptible to scams, you have an increased risk of getting dementia. If you're normal, you have increased Alzheimer's pathology in your brain. And why is this important? Because maybe it should be a trigger. Maybe people should get a PET scan once we have therapy for certain. If you're seeing that an older person is changing, having subjective complaints, is susceptible to scams, maybe that's an early indicator that there's a problem. So finally, I wanted just to end by talking about how there's still a lot we don't know about the aging brain. So we talked about how all these different pathologies are accumulating, they're causing decline. We should certainly be investigating how to resist getting these pathologies or be resilient to these pathologies. But what we find is that if we look at the variability in cognitive function in aging or cognitive decline, this is again in the Religious Order Study Memory and Aging Project, but other people have shown this too, is that we're not explaining a lot of the cognitive differences that we're seeing in older people still. So in this particular study, we found that we were only explaining a little less than a half. That residual cognitive decline we didn't understand at all, even with Alzheimer's, infarcts, Lewy bodies in this model. And there's a lot of interest in what this means. And not surprisingly, when you think about it, things like depression. Depression does not have a direct relationship with pathology, doesn't increase Alzheimer's disease, doesn't necessarily increase infarcts that we're aware of, but it's related to dementia. What we're finding is that we may be able to look for other changes in the brain that make you more susceptible to that depression-provoking Alzheimer's. And indeed, we found an insulin growth factor that seemed to promote dementia in people with depression. So I think it gives us a lot of information to have the brain and know what risk factors are or are not related to the pathologies. We discussed earlier vulnerability to stress, anxiety. This has been shown by multiple groups to increase the odds of an Alzheimer's type dementia. And again, the mechanism really isn't well known. What's happening? Another thing that happens is personality. So people with more obsessive personalities or people with more negative personalities are at a higher risk of having Alzheimer's disease. And we found that these things don't tend to be related to the pathologies we're finding in the brain. So is it that if you don't have that trait, you have some resistance? If you have that trait, it's causing cortisol release? I think there's still a lot of work to be done in what's promoting and what's preventing. We talked about seafood earlier, that seafood is supposed to be good for us, and that I showed you some relationship with neuropathology, but that's certainly for diet, not the whole effect. Why are people who eat a better diet healthier and have a lower risk of Alzheimer's disease? We really don't understand that. The vitamins certainly haven't seemed to work. And the one thing we were interested in here, which is interesting, is we thought to ourselves, well, if seafood's good for you, what about all that mercury people talk about that you can get in your brain? So we actually did a study looking at mercury in the brain in people who ate a lot of seafood, and we found a relationship. If you eat a lot of seafood, you have more mercury in your brain. But it did not negate the effect of beneficial effect of the seafood. There was no association between that mercury and at least cognitive impairment in our cohort. So when we recommend things to people, we have to be careful because we don't know what may be beneficial and harmful. Another example is iron. It's a nutrient that's extremely important and has lots of good effects in the right foods. But it also is a heavy metal, and there's lots of heavy metals around in pollution and in our environment, and there's a lot of interest now in what that's doing to our cognitive health. And I can tell you, at least in this one study, and we're doing more, that we found that brain iron is actually related to accelerated decline in people with Alzheimer's pathology. Now, I don't have any proof that it's environmental. I don't know exactly where it came from. We are doing studies to look at that. But it's interesting to think about all these other factors that can be interrelating with the pathologies or acting separate from the pathologies. And then again, just to end with, we don't know a lot about certain reasons older people decline. So one of the things that most physicians and family members know here is if your older loved one goes into the hospital, we all worry that they're going to take a steep decline after that hospitalization. And this has been known since I was a medical student, and yet we still don't really understand what's happening in the hospital. We were able to show that people who go to the hospital, they are declining a little bit more, then they have a hospitalization, and then they go through this really quick decline afterwards. And we're intensely studying what does that mean. And so far, we have found that those people do not have more pathology in their brain. So something else about that hospitalization seems to be promoting this decline. And we're very interested in, does delirium or neurotransmitter changes occur? What other things may be occurring during these hospitalizations? People are interested in surgery and in anesthesia. In this particular paper, we did show that the decline was after non-elective rather than elective hospitalizations, which I think is a positive thing. So the people in our study who electively went in to get a knee replacement or hip replacement, they actually did not have as much decline. So in conclusion, Alzheimer's disease, I hope I've convinced you, is a really complex brain disease, but it has many potential targets, which is really good news, right? There's a multitude of risk factors, protective factors, and better understanding this is really important. I think for now, we can be clear that controlling your vascular risk factors in general is going to be important when 75% of older people with dementia have these vascular changes in their brain. The other thing that I hope I convince you is that older people are going to develop pathology. There's going to be pathology in the brain. It'd be great if they didn't have it. Hopefully therapies will come where older people don't. But you can withstand it. There are ways to have this pathology in your brain and still be leading a normal and active life. And that's really good news, right? And that's why you can't get that PET scan with amyloid, because your doctor's not going to know what to tell you about your future as far as cognitive impairment right now. And then finally, there's a lot of unexplained cognitive change, and there's a lot of research needed with human brains to figure out what are these other changes that we're not picking up. Why is it that the mouse model doesn't have brain degeneration from amyloid and neurofibrillary tangles? The brains of people with Alzheimer's that come to the autopsy, they have tremendous neurodegeneration. Where is that missing link between that degeneration, the loss of neurons, and what's happening in the animal model? So really important to look in human brains to try to figure out what that difference is. So I just want to thank everybody that I work with. There's a very large team. Dr. David Bennett, who's the director of our program, Patricia Boyle, who's done a lot of the cognitive aging studies, Bob Wilson, a lot of the psychological work, personality work, Dr. Morris, who has done the nutritional studies, Dr. Barnes, who's done a lot of our racial work, and Dr. Arvanatakis, who's done a lot of the vascular studies. And then I especially want to thank our funding organizations, as well as our study participants in particular. I mean, all these older people we work with, they're still very busy. Many of them still work, many of them have social lives. They take a big part of their day yearly, or days for some of the things we do. They get MRI scans, they get cognitive testing, we get blood from them. So they really give a lot, and I do think that the gift is being returned to future generations. Thank you.